It's great to be with you again. This afternoon, I was asked to present on a comparison of myocarditis following vaccination with the mRNA vaccines for COVID and a historical form of myocarditis we see after typical Coxsackie or other viral infections. I'd like to acknowledge in the beginning that some of the world's experts in this topic are at your medical center. I wish I could be there to discuss your results, and I hope that what I'm going to present won't overlap too much with what is coming in the other presentations this afternoon. But in the next 20 minutes, we're going to focus on what I hope will be informative and somewhat unique data to highlight the importance of both patient-reported outcomes as well as major clinical adverse events in these studies. With that, I'm going to share my screen. And although I do consult from Moderna as part of their safety evaluation for their vaccine, I don't think that's going to have any impact on the content of this particular presentation. So I'm going to begin with what could be my concluding slide, which is the big picture. And that is that the SARS CoV2 variants, the vaccines and newer antivirals have changed over the past 3 years of the pandemic substantially. They vary both by region as well as temporally, and that is going to have a substantial impact on future recommendations regarding vaccination because the competing therapies will be evolving and the virulence of the virus will be changing. So today, the SARS CoV2 Omicron variant is, of course, more immune evasive and somewhat less virulent than the original or the Delta variants, which we struggled with in 2020 and 2021. And so much of the data I'm going to show you is derived from the experiences with vaccination in those first waves of the pandemic. And next year and the year after, there may be different conclusions regarding management depending on the evolution of the virus. So let's talk about historical viral myocarditis, its presentations and outcomes. We'll talk a little bit about the COVID-19 cardiac injury, and then the mRNA-associated cardiac injury, recognizing that there are going to be other presentations today which will cover some of this material. So myocarditis presents most commonly with chest pain, although historically it was identified in heart failure populations in the 1970s, 80s, and 90s. Chest pain can present as myopericarditis or as a chest pain-like syndrome resembling an acute myocardial infarction. Arrhythmias are far less common, but tragic, and there's a controversial area which we will not touch on today about chronic dilated cardiomyopathy and the role of inflammation in mediating a more chronic inflammatory process. These data, which are relatively recent from Germany, look at biopsy-proven viral myocarditis. And I think they're relevant because this was a relatively high-risk population. Everybody had a biopsy, everybody had viral genomes. And the topic of this conversation is really what is the outcome and the presentation of viral myocarditis. They demonstrated overall about a 3.9% risk of death per year for 10 years. And you can see in these 4 Kaplan-Meier curves that the risk varied depending on the severity of left ventricular dysfunction and the presence or absence of delayed enhancement on MRI. If you had bad heart function and scar on MRI, your risk was much higher than if you had good heart function. And that's still true today, both for the SARS-CoV-2 as well as the other routine viral myocarditis that we see. So what about viral myocarditis in the United States? From 2005 to 2014, these data were published a couple of years ago, looking at 37,000 patients hospitalized with a diagnosis of myocarditis. And you can see there was a pretty high risk, 4.4% in-hospital mortality. By 2014, there was a 2% use of ECMO and a 2% use of peripheral ventricular devices with about a 10 to 12% rate of cardiogenic shock. So viral myocarditis in the pre-SARS-CoV-2 era was pretty bad stuff on average if you made it to the hospital. And there was a risk of heart failure, death, and transplant on the order of perhaps 5% per year, depending on the presenting symptoms and the age and the heart function. But historically, chest pain did pretty well. If you presented with myocarditis, and this is a study from Italy a few years ago, looking at almost all males with normal LV function and chest pain presentations, no real heart failure in the group, their risk of death or transplant was about 1% per year in the uncomplicated group. There was a higher risk if you had anteroceptal delayed enhancement pattern on your MRI, but we'll come back to that as a separate issue. Perhaps that reflected arrhythmogenic cardiomyopathy in this northern Italian group. It's not clear. The definition of myocarditis is also important for the purposes of this discussion. Historically, in the 70s, 80s, and 90s, it was heart biopsy. In the 2000s and more currently, it's been cardiac MRI, or sometimes for sarcoid PET scanning. But for the purposes of vaccine myocarditis, it's often a clinical case definition, which can be CDC, which was first developed for the smallpox vaccine in 2003 and modified a little bit for the current pandemic, and the Brighton criteria, which were published in March last year in Vaccine. This is the CDC summary of 3 tiers of certainty: suspected, probable, and confirmed. Very few cases are confirmed unless there's an autopsy or a heart biopsy, and most of these patients don't have heart failure, at least not the ones with vaccine-associated myocarditis. So almost everybody is diagnosed based upon a clinical syndrome with elevated troponin and or new echo abnormalities or a compatible MRI. That's different than the diagnosis by heart biopsy, which was in a more severely ill group back 20 or 30 years ago. So let's look at some comparator data. We're going to start with data purposefully not from Israel. These are data from Hong Kong that came out a couple months ago, which I wanted to show first because they're new and a little bit different. This looked at 762 patients from Hong Kong who historically had been diagnosed with viral myocarditis versus 100 and compared to 104 patients who had Pfizer vaccine-associated myocarditis in the past year. And you can see on the right that the risk of heart failure in the historical group was 12.2%. The risk of mortality was 11%. And that was dramatically higher than the group here in blue, with a 1% mortality and a 1% risk of dilated cardiomyopathy. And even that's a bit high compared to other groups of vaccine-associated myocarditis. But it gets to the point that the current flavor and severity of myocarditis in COVID-19 vaccine-associated disease is real, and particularly the vaccine-associated myocarditis tends to be much less severe than the historical rates. Moving on to what I consider some of the world's best data from Israel. This was the BARDA paper, of course, August of a year ago, which showed that there was a statistically significant increase in the rate of Pfizer vaccine-associated myocarditis, but that it was not nearly as high as the risk associated with the actual SARS CoV2 virus itself, 3 per 100,000 versus 11 per 100,000. The context here is that the risk of arrhythmia, of course, was much higher, 166 per 100,000 in the virus group versus a little protective effect, -6 in the vaccine group. And very important data, very detailed. All the cases were confirmed. And when we look moving forward at the United Kingdom and Denmark and Ontario, Canada, and the VAERS data, they're very similar patterns. These are the data that came out of the United Kingdom, 40 million approximately cases. And to put this in context, if you're not familiar with this figure, the adenovirus vaccine is on the left, first and second doses in these 4 panels. The Pfizer is in the middle for the first and second doses. Moderna, the mRNA 1273 is the next 2 columns, first and second doses. Then on the far right of each panel is SARS CoV2 positive itself. So this is the virus infection itself. So the risk of myocarditis, if you actually got the virus in the UK study, was about 40 per million. 4 per 100,000, which is much higher than either the first or second dose of Moderna. And they really didn't pick up a signal initially on this figure for the overall population. If you look at the under 40s, males and females, there was still a 10 per million, 1 per 100,000 risk of myocarditis following a positive SARS-CoV-2 test, and about 15 per 100,000 or 8 per 100,000 for the Moderna second and first vaccine. And then with Pfizer, there was a signal after the first and second vaccine as well in those under age 40. They did break out pericarditis, which was good. Not every country did that. And some people combined the pericarditis and myocarditis data, which I think was a bit confusing. But you can see here a significantly increased risk of pericarditis at 6 per 100,000. Again, the cardiac arrhythmias here with the virus itself were in the 2,400 range, right? Thousands, not single digits, with very low numbers following the 3 vaccines that they looked at. Now, it's worth noting that larger data sets that have come out more recently do suggest that some vaccine-associated pericarditis in the mRNA vaccines, possibly with other vaccines. And we don't know about the Russian or the Chinese vaccines I'll mention. So what about the young people? So mainly vaccine-associated myocarditis affects young males, and mainly after the second dose. Ages 12 to 21 in this study, which was a US study published a little over a year ago in Circulation, 139 cases from 26 centers, demonstrating what we see in Israel and UK and other patterns, that about 90% of vaccine-associated myocarditis is in males, 99% roughly chest pain, and only 2 of 139 required inotropes or vasopressors. There were no deaths, and there was no need for ECMO in this cohort, and all those patients who had an ejection fraction of less than 55% normalized by the end of the study, which was not very long. So important to realize that this is a relatively mild event. There are some severe cases, there are rare deaths, but by and large, this is not the kind of viral myocarditis that we were seeing 20 or 30 years ago. So what about the young athletes? I'm not going to go into detail, but simply say that when people prospectively looked at the actual infection, the SARS-CoV-2 infection itself in young athletes with MRI, there was a small rate of positive MRIs, about 2.3%, most of which were subclinical. 75% were subclinical. We haven't seen a lot of sudden cardiac death or arrhythmias in this population. And so my takeaway from this is that our current recommendations, which is to abstain from competitive sports for 10 days or so, and then gradually return to activity if there are no cardiac symptoms, are probably the right way to go without any advanced imaging. So how do you put this together into a recommendation for the young individuals? The 2022 ACC consensus statement on the management of myocarditis after the SARS-CoV-2 infection and return to play came up with this integrated figure that essentially in the 12 to 29-year-old male group, which has the highest risk of myocarditis, you would still prevent 560 fewer hospitalizations, 138 fewer ICU admissions, and 6 fewer deaths at the price of 39 to 47 more cases of relatively mild myocarditis. Now, the risk-benefit ratio may change in the future, but at least as of today, this is what we're recommending: stick with the vaccine. There are 2 other important things to mention. The first is long-term outcomes. I note here that there is an increased risk of inflammatory heart disease more chronically, but it's not nearly as large as the risk of dysrhythmias. And this is from the VA cohort published this past year, looking at about 150,000 individuals, long-term outcomes of COVID-19. Again, important takeaways: management remains somewhat uncertain, mechanisms remain somewhat uncertain. The second point is the burden of depression and anxiety. This paper came out in the fall if you're interested, Enrico Amarita and I wrote the editorial, which focuses on patient-reported outcomes. And in these relatively young individuals, 12 to 29 years old, from the VAERS data set, who completed a questionnaire regarding their quality of life, there was a 46% rate of anxiety or depression, which was much higher than was appreciated by their healthcare providers. This is true not only for vaccine-associated myocarditis, but for all kinds of heart diseases. But it is underappreciated, in my opinion, that we focus on death, transplant, and heart failure appropriately. But we should also focus on these modifiable psychosocial impacts. So with that, I'm going to stop. I'd like to thank you very much for your attention and say that I'm available should you have any questions regarding this by email or follow during this meeting or thereafter.